Thank you, Elizabeth, for that kind introduction. Good morning, everyone. I'm Michael Perelman, and regrettably, I'm in Chicago right now due to a family obligation. I'd hoped to attend both STAR and my family's event, but the travel schedule made that impossible in the end. However, the program committee graciously asked me for a video. I'm pleased that this section of the program is empirical, but having done empirical research myself, I must tell you we should only consider this a commentary. These are my disclosures. Although mind-body connection concepts are older than Descartes, it was George Engel's work that helped encourage almost all of us to replace the medical model with a biopsychosocial one. The biopsychosocial model, as you know, has gradually become the global gold standard for sex therapy and sexual medicine. The model has clear utility and it's easily pronounced. However, given its importance as the current gold standard in our field, it's incumbent for each of us to periodically re-examine how we apply it and why. Because we all need to make sure we're applying the model in a manner that optimizes its strengths and minimizes its limitations. Most sex therapy practitioners and sexual medicine physicians pay lip service to using the model for diagnosis and treatment. However, it's my observation after 50 years in this field that each group tends to focus on one or perhaps two aspects of the model overly exclusively, with insufficient awareness or attention to other contributing factors. Now, examining one's approach will remind us of criteria that we are using productively already, but it will also alert us to blind spots resulting from specialized training cultivated within our professions of origin. During much of the 20th century, psychosocial factors were given great prominence, first by psychoanalysts and later by sex therapists who typically were mental health professionals. It seems to me that too many mental health professionals still fail to sufficiently attend to the biomedical aspects of a patient's complaint, both in terms of understanding etiology and in planning treatment. That's despite a stated allegiance to a biopsychosocial model. It's not just the therapists, of course, who are biased at times, as most physicians do not truly attend to the cognitive, emotional, behavioral, and cultural factors contributing or exacerbating a sexual disorder. Few physicians, when prescribing medications to improve sexual function, inquire of the patient or of their partners if the patient's goals for sexual activity are aligned with those of their partner. Even for those physicians who might prefer in-depth assessment, the time limitations of most physician and even specialist office visits typically negate the potential for multi-layered engagement. A setback for the biopsychosocial model was the Viagra launch with its emphasis on medicalization. The corresponding impact of Viagra catalyzed the ascendancy of urology as quote-unquote sexual medicine experts over the other specialties which had traditionally managed sexual issues. To give you a first-hand account, Pfizer recruited me to join a panel of 3 urologists to launch Viagra at the 1998 AUA annual meeting. Now, each urologist got 10 minutes to describe their Viagra clinical trials. I was only given 2 minutes to give, quote-unquote, the psychological balance to the medical equation. Now, memorably, at least to me, the head of urology at New York Montefiore Hospital yells out from the back of the room, "Michael, sex therapists will go the way of the dinosaurs." Now, of course, the audience laughs, but fortunately, to paraphrase Mark Twain, that announcement turned out to be premature. Sexual medicine's initial leaning towards the medical model was now reinforced by the medicalization inherent in pharma's marketing of PDE5 inhibitors. However, gradually things were rebalanced as sexual medicine progressively adopted a biopsychosocial perspective during the early 21st century, facilitated by the emergence of reformed and newly multidisciplinary societies. So some of them, like SSI, became SMSNA, ISSR, became ISSM, and there's no doubt it was the presence and valued participation of female clinicians and researchers, as well as mental health professionals, that helped lead the charge. Now, take my word for this. I was there when it all began, and I was there when it changed again for the better. And to name a few involved, amongst others, Sandy Lieblam, Ray Rosen at Rutgers, Stan Altoff in Cleveland, Leonore Tiefer and Miriam Dunn in New York, Daniel Whitman in Michigan, and myself, who were all STAR members, made a difference. By the way, while STAR has always been multidisciplinary to its credit, STAR's membership origins as East were disproportionately male physicians, many of whom had strong biomedical biases. Now, but reciprocally as STAR, we've benefited greatly from expansion and expanding our members' diversity, including many more mental health professionals. But too often it does seem that biomedical gets overlooked, or at least underexplored. Finally, while not well studied, how many of us really provide fully competent cultural awareness and sensitivity when evaluating and treating our patients? Telehealth and the flattening of the world allows access to patients from just across the globe. That creates an ever-increasing need for practitioner sensitivity to the different patient populations, given the implicit diversity regarding sexual practices, gender identification, and sexual orientation. The failure by many to address those preceding issues strongly suggests that despite almost all of us paying lip service to a biopsychosocial perspective, that model is not fully guiding the practice of many clinicians, regardless of their profession of origin. So what's the solution? Perhaps for some of you, the sexual tipping point model may offer some useful reminders. The STP is an easy way to remain mindful of all the mental and physical elements of sexual function and dysfunction. Allow me to digress for a moment just to acknowledge my own mentor, Helen Kaplan. Since its publication, her dual control sketch in her 1995 last book has influenced my thinking, and it foreshadowed both John Bancroft and my own work on dual control models of sexual response and its disorders. I focused on the clinical implications of a variable dual control sexual tipping point model. It received some attention and was granted a trademark by the U.S. Patent Office in 2007. It was also helpful in a 2008 invitation to teach the STP and an NIH-sponsored workshop to assist young neurology scholars to communicate complex discoveries in simpler language to the public. But what really changed the model's acceptance came unexpectedly when I was explaining it to a multidisciplinary group of experts at Behringer's Neurobiology Advisory Board. Now, Jim Faust, the famous rat researcher, he thought this was hysterical, and he filmed me. But he also included an illustration of the model in his highly cited article, Pathways of Desire. BI had hired a media company to produce images for them, and Shaw Science licensed the model for their film that explained desire. So I donated the rights to the model to a foundation I started in 2011 so that the money accruing from it could be used to encourage young sex therapy researchers. BI left the sexual medicine business, selling fulvestrant to Sprout Pharma, but the film never saw the light of day. Fortunately, friends knowing all this have donated money to this charity, allowing me to present the STP awards like the one being given out later today. In all these cartoons, I use both sliders and dimmers interchangeably to illustrate the variability of sexual response. Each dimmer is a micro-variable switch that symbolizes a factor's varying polarity, with some of them being positive, some negative, some neutral, and of course some are unknown at this time, and I wanted to leave room for future discoveries in the way the model worked. The dimmer size in the mental and physical containers show the magnitude of the factor. The net sum of all these factors determines the STP, shown on the sexual balance scale at any moment in time. When a mental and physical container And why on both sides? Because sex is always both mental and physical, whether excited or inhibited. It's sort of like a four-way matrix. Excitatory and inhibitory processes can occur simultaneously, and their balance determines the overall sexual response. But changes in polarity and magnitude can be bidirectional. Mentally, a once desired touch can become traumatizing after rape, of course. Feeling great helps, illness inhibits. You're diagnosed with COVID, you don't feel like having sex. Now, that's despite the person having the exact same genetics they were born with, so it's not a question in that case of predetermination. Now, we know sex drug effects can be bidirectional. Viagra can help excite. High blood pressure medications can inhibit. SSRIs are well known for their inhibition or at least diminished reaction of orgasm, especially in women. And common objects can become fetishes like Mrs. Robinson's stockings in The Graduate. Clearly a movie reference that dates me. This STP cartoon actually depicts a real case. A man was referred to me for ED treatment, secondary to his ex-wife humiliating him. She yelled out in open court during their divorce, "You are the worst lover I ever had." He came to see me 2 years after the incident. The cartoon shows the breakdown of various potential factors I considered related to his chief complaint. The red and blue sliders are numbered and lettered. The M's are the mental factors, the P numbers are the physical factors. Each numbered and colored ball is then placed on the balance beam tray, tilting the sexual tipping point towards sexual excitement or inhibition. I want to pause for a second just so we can read these lists of key factors, or at least some of them are key factors. Clearly thoughts about what happened, his feelings of humiliation. He had confusion regarding interpersonal relations, and he actually tried going out on a date after a couple months and had a sexual experience, but while pleasurable, it was just insufficient to trump the inhibitions he was feeling, and he was unable to perform. Then he'd gone for an unsuccessful psychotherapy. It was a supportive therapy. It helped him feel a little bit better about himself, but nonetheless, no improvement in his erections, perhaps not surprisingly. In terms of physical factors, anatomically, he may have been predisposed. Some people get headaches, some people get stomach aches, some people get sexual problems. Not everybody who hears like a mean, nasty comment about their performance avoids having sex for a couple of years. Unfortunately, he began drinking too much to manage his quote-unquote bad feelings. It turned out he had low testosterone, which we had diagnosed, evaluated, and treated. Genetically, he may have been predisposed. Perhaps some of that predisposition was some neurosensitivity, as we were just talking about before. And importantly, there's unknown factors, but God knows the above is enough already. He did go to a urologist soon after he had that failing experience with the one woman. And the doctor did give him a PDE5 inhibitor. But unfortunately, there was insufficient dosing guidance. He never went back to that doctor, and that led to more negative self-effacing thoughts. By the way, the "and" in the center between all those arrows is... it reflects the fact that the line between mental and physical is porous. That's what all those little dots are that you see. Thoughts become translated into biochemical, electrical components. Listen, do I really believe or expect anyone else to diagram this out in the sort of obsessive way that I've done here, like some fifth grade English diagnostic English assignment or something? No, of course not. But the cartoon is there to remind us to consider all the multiple potential factors and not just the ones we're comfortable with identifying. Both physician and non-physicians alike are siloed, leading to myopic patient care. For me, at least, keeping all this in the back of my mind helps me keep a more open perspective. As I'm not there to answer Q&A, please allow me to take just another minute to provide some quick take-home messages. First, given the biopsychosocial model's importance to our field, periodically we need to re-examine how it's understood and applied. Second, to re-examine will remind us of criteria we use productively, but also alert us to blind spots that we need to be aware of. Third, the term must be viewed as a stand-in for all the predisposing, precipitating, and maintaining biological, medical, surgical, cognitive, behavioral, emotional, social, and cultural factors involved in the etiology and treatment of sexual disorders. Those factors are best understood at a granular level. You got to get the details based on their proportional contribution, because it's going to vary to the whole for a true grasp of an individual's experience. Now, despite increasing respect paid to each other by the various professions, our viewpoints do still remain too separated. The understanding and treatment of sexual disorders is best accomplished through an integrated, transdisciplinary approach that offers more than just combining techniques. One such approach can be illustrated using the sexual tipping point model. Now, apologies again for not being present for the Q&A, but hope you found this presentation of some interest. Please feel free to reach out to me with questions, and the QR code for the foundation is up on the